Hello everyone and welcome. As anesthesiologists, we work in an environment where the threat of infection is a constant companion. In this explainer, we're going to dive deep into that threat, focusing on how we can really master the management of infectious diseases, from the everyday to the extraordinary, in our day-to-day practice.
Right, let's get started. Think of this session as a kind of digital grand rounds. It's a comprehensive review designed to be a really valuable piece of continuing education. We're going to cover everything from the absolute fundamentals of perioperative infection all the way to the front lines. And yes, that includes the incredibly tough lessons we all learned from the COVID-19 pandemic.
So here's how we're going to break it down today. We'll kick things off with the big picture, the universal principles of preventing infections in the first place. Then we'll zoom in on some specific and often tricky areas, the gut, the skin, and of course, the lungs. After that, we'll dedicate a big chunk of our time to an in-depth look at COVID-19 management, and we'll wrap it all up with a case review to see how all this theory actually plays out in a real clinical scenario.
Okay, let's jump into our first section. The reality is, every single patient who comes for an operation is at risk of picking up an infection. Our role as perioperative physicians goes way beyond just the anesthetic itself. We're also the gatekeepers, the guardians against these infectious threats. And one of the biggest ones we face are surgical site infections, or SSIs.
And you know, the stakes here are incredibly high. An SSI isn't just a minor complication. It's a major driver of morbidity and mortality. Just think about it. A patient who develops an SSI is 5 times more likely to be readmitted to hospital and, shockingly, twice as likely to die. And this number here, a 60% higher chance of ending up in the ICU, that really drives home how devastating these infections can be. They can turn what should have been a routine procedure into an absolute critical care nightmare.
So, to prevent them, we first have to understand the risks, and it's a really multifactorial puzzle. The risk factors tend to fall into 3 main buckets. First up, you've got the patient-related factors. These are things we assess every day: extremes of age, poor nutrition, a high ASA score, and of course, comorbidities like diabetes and obesity. Then there are the microbial factors, things like how nasty a particular bug is, its virulence, or its ability to create a biofilm, which is exactly why infections on prosthetics are so tough to treat. And finally, you have the wound-related factors. Things like devitalized tissue or a hematoma can literally create the perfect breeding ground for bacteria to thrive.
And how do we actually diagnose an SSI? Well, we use clear, standardized criteria that classify them by how deep they go. A superficial infection is just in the skin and subcutaneous tissue, and you'll usually diagnose it by seeing purulent drainage within about 30 days. Deeper infections are more serious, getting into the fascia and muscle. They might present with pus deep in the wound or even the wound splitting open on its own. And then you have the most severe type, an organ or space SSI. This involves any area that was messed with during surgery, and it's often picked up as an abscess on an imaging scan or pus coming from a drain.
Now, this is where we can make a huge difference. As anesthesiologists, we are in a brilliant position to reduce these risks before the patient even gets to the theater. The things on the slide are absolutely fundamental. Any active infections, they have to be treated before an elective case. We know that getting patients to stop smoking for at least 4 to 8 weeks massively improves wound healing. We should also be tackling malnutrition, getting blood sugars under control, and encouraging patients to stop drinking alcohol. And a couple of really key things. Screening for and decolonizing S. aureus caries with something like topical mupirocin can be incredibly effective. And such a simple change, from shaving the surgical site to clipping, makes a big difference by reducing those tiny cuts that act as an open door for bacteria.
Of course, our most direct weapon is antibiotic prophylaxis, and with this, precision is everything. These guidelines are our playbook. Timing is absolutely crucial. Giving that dose within 1 hour of the incision ensures you have the highest concentration of the drug in the tissues right when the surgeon makes the cut. The choice of drug, well, that depends on the surgery and the bugs we expect to see. The dose might need to be increased for obese patients. And for long cases, or those with a lot of blood loss, redosing is vital. And a really important point on antibiotic stewardship: stopping the prophylaxis within 24 hours is key to fighting the growing problem of antibiotic resistance.
Right, so while we're really focused on what's happening at the surgical site, we can't forget about the lifelines we put in, the direct access we create into the patient's bloodstream. The bloodstream itself is a vulnerable space, and bloodstream infections, or BSIs, are a massive threat. They are one of the top 3 hospital-acquired infections. And you know what the main culprit is? Something we put in all the time: the central venous catheter.
The brilliant news here is that catheter-related BSIs are almost entirely preventable. The CDC has put together 5 key interventions that form a really powerful care bundle. Honestly,
these should be completely non-negotiable every single time a line is placed. It all starts with the basics, meticulous hand hygiene. Then, using full barrier precautions. We're talking hat, mask, sterile gown, and a big sterile drape. Cleaning the skin with chlorhexidine has been proven to be better than other agents. Avoiding the femoral site is crucial because it has much higher rates of bacterial colonization. And finally, the simplest rule of all. Check every day if that line is still needed. If it's not, get it out.
Now, when an infection isn't contained, it can spiral out of control into sepsis. And it's really important to understand that sepsis isn't just a bad infection. It's the body's own response going haywire. It's a systemic, dysregulated host response that starts to cause organ dysfunction. The best way to think of it is as a continuum, or maybe a slippery slope. It starts with a local infection, which then triggers a systemic inflammatory response. That can progress to severe sepsis, where organs start to fail, and finally to septic shock, where the patient's blood pressure stays dangerously low despite giving them lots of fluid. And at that point, the mortality rate can be over 40%.
So, for a patient with sepsis who needs an emergency operation for source control, our preoperative job is all about aggressive, goal-directed resuscitation. We can't always wait for the infection to be completely gone, but we absolutely must get the patient's physiology into the best possible shape. These targets here are our guideposts. We're aiming for a MAP above 65 to ensure organ perfusion. We want to make sure the tank is full with a CVP between 8 and 12. We're watching for good urine output, correcting any metabolic acidosis, and, critically, making sure we're delivering enough oxygen to the tissues, which we can track with a mixed venous oxygen saturation above 70%. This isn't about delaying surgery, it's about making sure the patient can actually survive it.
Okay, let's move into our second section. Here, we're going to focus on some really specific and often very challenging infections of the GI and cutaneous systems. These patients often turn up as emergencies, and they require a really clever and careful anesthetic approach. First up, Clostridium difficile, or C. diff as we all know it. This is the main cause of antibiotic-associated colitis. And let me tell you, when a patient with fulminant C. diff colitis needs a subtotal colectomy, they are probably among the sickest patients you will ever look after. The anesthetic challenge is just immense. These patients come to us severely dehydrated with profound electrolyte and acid-base chaos from the diarrhea, and they are almost always hemodynamically unstable from septic shock.
So, here are some absolutely crucial takeaways from managing these cases. From a purely practical point of view, scheduling the surgery at the end of the day is a massive help. This gives the hospital the time it needs for the enhanced terminal cleaning that's required to get rid of those incredibly tough C. diff spores from the theater. Intraoperatively, just expect severe instability. That means having an arterial line and central access in from the very beginning with your vasopressors and inotropes drawn up and ready to go. A key pharmacological point, be really careful with opiates. They can slow down the gut, which might actually make the disease worse by increasing the time the toxin is in contact with the bowel wall. And post-op, infection control is paramount. Those spores are famously resistant to alcohol gels. The only thing that works is vigorous hand washing with good old soap and water to physically remove them.
Now let's move to the skin and talk about necrotizing soft tissue infection, or NSTI. This quote just captures the dangerously deceptive nature of this disease perfectly. What you see on the surface, maybe just a bit of redness or swelling, can completely hide the massive, deep tissue death that's happening underneath. These infections, like Fournier's gangrene, progress with terrifying speed and have an incredibly high mortality rate. They are true surgical emergencies.
The core principle for managing NSTI is this, and it's simple. You are managing severe sepsis. Everything we just talked about with goal-directed resuscitation applies here. But, and this is a huge but, resuscitation must not delay the definitive treatment, which is urgent and aggressive surgical debridement. Every single hour of delay is linked to a significant jump in mortality. Our job is to resuscitate as fast as we can to get the patient to theater as safely and as quickly as humanly possible. This same principle, fast resuscitation followed by urgent source control, applies to tetanus too, though with tetanus we have the added challenges of dealing with severe muscle spasms and wild autonomic instability.
Right, for our third section, let's turn our attention to the respiratory system. Respiratory infections bring a whole unique set of challenges for us as anesthesiologists. They directly mess with gas exchange and airway management, and of course, they often come with major infection control implications.
Let's start with ventilator-associated pneumonia, VAP. This is a really common complication in the ICU, and it's defined as a pneumonia that pops up at least 48 hours after a patient has been intubated. The diagnosis can be really tricky because telling it apart from things like ARDS or pulmonary edema isn't always straightforward. That's where a standardized tool like the Clinical Pulmonary Infection Score or CPIS comes in handy. A score over 6, which is based on things like temperature, white cell count, what the secretions look like, oxygenation, and the chest X-ray, is highly suggestive that you're dealing with VAP.
Patients with VAP often need to come to theatre for a tracheostomy. When they do, our #1 goal is to make sure they don't suffer any clinical setback because of the procedure. That means we have to avoid de-recruitment, hypoxia, or any hemodynamic instability. It starts before we even move the patient. If they are on maximum support with hardly any pulmonary reserve, it might just be too risky to proceed. During transport, it is absolutely essential to use a PEEP valve on the transport bag to stop the alveolar from collapsing. And in theatre, we must try to replicate their ICU ventilator settings as closely as we can, especially their PEEP level, and use a lung protective ventilation strategy throughout.
Now for tuberculosis, an airborne pathogen that demands incredibly strict precautions. For any elective surgery, you have to postpone it until the patient is confirmed to be non-infectious, which usually means getting 3 consecutive negative sputum smears. For urgent cases, the rules on this slide are completely mandatory. The procedure has to happen in a negative pressure operating theater. The patient and every single member of staff must wear N95 masks. You have to place a HEPA filter on the expiratory limb of the breathing circuit, and if you can, use a dedicated anesthesia machine that can be thoroughly decontaminated afterwards. There are no shortcuts here.
Managing immunosuppressed patients, like solid organ transplant recipients, means we need to understand their specific windows of vulnerability. And this timeline here illustrates a really predictable pattern of risk. In that first month after a transplant, the infections are usually bacterial or fungal, and they're often linked to the surgery itself. Then, between months 2 and 6, their immunosuppression is at its absolute peak. This is the classic time for opportunistic infections like PCP or viral reactivations like CMV to appear. Then after 6 months, as their immunosuppression is usually tapered down a bit, they become more susceptible to the sort of standard community-acquired infections that we all get.
And of course, from a pharmacology perspective, we have to be really aware of potential drug interactions. For our transplant patients, a drug like cyclosporin can slow down the metabolism of certain neuromuscular blockers, which could mean their paralysis lasts a lot longer than you expect. For patients with HIV on highly active antiretroviral therapy, or HAART, the situation is even more complex. These drug cocktails can inhibit or induce cytochrome P450 enzymes, which can have a huge effect on how we metabolize opioids, benzodiazepines, and other anesthetic drugs. A thorough medication review, and maybe even a quick chat with an infectious disease pharmacist, is absolutely essential.
And now we have to turn to the defining infectious disease challenge of our generation, COVID-19. The pandemic forced all of us to completely rethink our practices, to rapidly develop and implement new protocols for perioperative care, constantly balancing the needs of our patients with the safety of our teams.
So let's start by reminding ourselves who is most at risk. This chart breaks down the key predictors for critical outcomes. On the left, we've got those pre-existing conditions that became all too familiar: cardiovascular disease, diabetes, obesity, and chronic lung disease. When patients with these conditions presented with symptoms like a high respiratory rate or severe breathlessness, and their labs showed specific abnormalities like lymphopenia, a high D-dimer, and raised cardiac markers, we knew they were at the highest risk of deteriorating.
Understanding exactly how the virus spread was the key to protecting ourselves. There are 3 main ways. You've got droplet transmission, which is from large respiratory particles when someone coughs or sneezes. Then there's contact transmission, either by direct touch or, much more commonly in our workspace, by touching contaminated surfaces or fomites. And then the one that worried us the most, airborne transmission, via much smaller aerosolized particles that can be generated during high-risk procedures like intubation, extubation, and even just using high-flow nasal oxygen. This understanding of transmission led directly to specific, practical IPC measures. We learned that the virus could survive on surfaces for days, which made decontamination absolutely critical. Luckily, it's susceptible to common, low-level disinfectants. A really simple but effective strategy was putting disposable plastic covers over high-touch surfaces like our monitors and keyboards. In the breathing circuit, a HEPA filter became standard practice, and changing filters and the soda lime after every single case became mandatory to prevent any chance of cross-contamination.
Right, so we've covered a lot of theory. Let's now try to consolidate all these principles by walking through a case. This will let us see how all that theory on infection control and anesthetic management was actually applied in a real-world, high-stakes scenario during the height of the pandemic.
So here's our patient, a 66-year-old man with a list of comorbidities, diabetes, hypertension. He comes in with that classic triad of symptoms: fever, cough, and shortness of breath. But what makes this an emergency is that he's septic from a large carbuncle on his back that needs urgent surgical drainage. At this point in time, his COVID swab result wasn't back yet, so he had to be managed as a high suspicion case.
The whole process began with transport. As you can see from these images, meticulous protocols were put in place to contain the virus. The patient's trolley was completely covered with a plastic sheet. Signs were put up, and the entire transport route from A&E to the operating theater was cleared of all other people to minimize any potential exposure.
And just look at the level of PPE shown here. For a high suspicion case like this, the minimum requirement was a powered air purifying respirator, a PAPR. This was worn with a full disposable gown, double gloves, and as you can see, an extra cape to protect the neck and ear areas which are often exposed. This level of protection was absolutely essential for any staff involved in aerosol-generating procedures.
The facility itself had to be adapted. A designated operating theater complex, completely separate from the main suite, was used. Now, while a negative pressure room was the ideal, here they adapted by managing the airflow to maintain a unit-directional workflow, as you can see in the diagram. Staff moved in a single direction through separate donning and doffing areas to prevent any cross-contamination. The air exchange rate in the room was also cranked up to its maximum to clear the air as quickly as possible.
And this all leads to the highest risk moment of all, securing the airway. A modified rapid sequence induction was the technique we all used. It started with thorough pre-oxygenation to give us the longest possible apneic window. Crucially, mask ventilation was completely avoided to prevent generating aerosols. We had to be certain of deep muscle paralysis before any instrument went near the airway. And the intubation itself was always performed by the most experienced anesthesist in the room, using a video laryngoscope to increase the chance of first-pass success and to keep a bit more distance from the patient's airway.
This case, even though the patient's test ultimately came back negative, is a perfect demonstration of the incredible systems and protocols that were developed out of sheer necessity. And it leaves us with a really critical question to think about. The COVID-19 pandemic was a true trial by fire, but it has left us with a solid framework for managing highly infectious patients. So as we look to the future, the challenge for us is to figure out which of these measures we should keep, how we can make them even better, and how we can stay ready to adapt them for the next inevitable infectious disease outbreak, so we can always ensure we protect our patients, our colleagues, and of course ourselves.